Good morning. This is Gary Greenswag, and first, thanks for joining us. We are very happy to be with a team of experts in the area of pediatric behavioral health. Comment that we are a string of three. A few weeks ago, we had diagnosis and treatment of depression in adults. Today, we have treatment of depression in adult children and adolescents. And I believe it's next week on the, well, no, it's a few weeks on the 29th. Is that the right day? 29th?
Next week. We have
it is next week. Okay, I apologize. We have a very interesting lecture on suicidality assessment. And so this is part of a series of three, as I think people are aware. September is National Suicide Prevention Month, and September 17th was Physician Suicide Awareness Day. All of this work corresponds with work that is taking place across Common Spirit in doing diagnosis and treatment of depression. Deborah Rockman and her team, Dr. Sagar and others, have been working diligently to help create workflows so that all of our patients during their annual visits can have suicide screening. And I would say that the preliminary results show that we are doing pretty well. So I think that's all good. It's been a huge amount of work, and not just the screening itself, but there's been a treasure trove of supporting documentation and treatment algorithms that have been put together for both adults and children. And so with that, I am going to introduce our speakers and then turn it over to Dr. Dudas for some comments. First, Dr. Jyotsna Ranga, who has been with us several times before on these calls and for Lunch and Learns, and we are very grateful for that, is the Associate Professor and Vice Chair of Adolescent Psychiatry at the Creighton University School of Medicine and Director of the Psychiatry Residency and Child and Adolescent Fellowship Programs at Creighton University. She completed her medical training at the Bangalore Medical College in India, and completed her psychiatry residency and child and adolescent psychiatry fellowship at the University of Missouri at Columbia. Her clinical work is in the child and adolescent psychiatry teaching clinic at Emmanuel Center in Omaha. Her research interest is in culture, diversity, and stigma, and has presented these topics at the American Academy of Child and Adolescent Psychiatry. She enjoys outpatient work and building an alliance with children and their families over time. So welcome, Dr. Ranga. Dr. Scott Piazza is also joining us. He is a fellow family medicine physician in the California Central Coast, where he provides care to adult and pediatric patients in the inpatient and ambulatory setting. He's a member of the Physician Enterprise Ambulatory Pediatric Collaborative and heavily involved in multiple quality and informatics efforts throughout the ministry. He attended the Arizona College of Osteopathic Medicine in Phoenix, Arizona, and then completed his residency at Marian Regional Medical Center in Santa Maria, California. He's board certified in both family medicine and clinical informatics. Welcome, Dr. Piazza. And last but not least, Dr. Michael Dudas, who is fresh off the plane from an airplane adventure, which we won't discuss during this call. He is a general pediatrician and chief of pediatrics at the Virginia Mason Franciscan Health. Deputy Chief. He also serves as the chair of the Physician Enterprise Ambulatory Pediatric Collaborative. He completed medical school at the University of Pittsburgh and his pediatric residency at the University of Washington. So welcome, Dr. Dudas. So with that, I'm going to turn this over to Dr. Dudas. I want to thank everybody again for attending. Turn this over to Dr. Dudas, and we'll get started.
Hi, good morning, everyone. I hope you can hear me okay. Great, thank you. Yeah, I'm excited to be here as well this morning and participate, introducing our speaker and our topic today. I've been chair of our Ambulatory Pediatric Collaborative, which has been, I think, together now for a few years. We have been focused with a really great team who's very passionate about pediatric care on really focused around the pediatric roots of adult disease. And especially through the pandemic, but even going into it and now with where we're at now, so much of it has been focused on behavioral health. We did a survey of pediatric providers within our system last winter, and most of what individuals find they need support for themselves and for their systems and for their patients is really around good behavioral health care for their pediatric patients. So we're excited to be able to find ways such as this to support that. The clinical standards team has been focused hard this year around depression screening, and we've been excited to be a part of that work, supporting these guidelines and helping to implement them. And this is just, as you heard from Gary, one more step in that process. So without further comment, I guess, I'm excited to have Dr. Ranga join us and give us a presentation, and then we'll be back to join the panel as she completes her talk.
Good morning. It is a privilege to be with you all today. Just checking my technology to make sure you can hear me correctly. My task today is to focus on pediatric or youth depression and specific focus on treatment. So our learning objectives are that at the end of the presentation, participants will be able to identify depressive disorders in youth, decide on the best course of treatment, and identify challenges and solutions. There are some key facts that I find important to go through, and I think to underline how serious this situation is for us. The point prevalence in pediatric or primary care settings is 28%, and only 50% of the adolescents who are depressed get diagnosed before adulthood. So there's a lot that we can do. Successful referral and completion of pediatric mental health consults are low. And unfortunately, we have a critical shortage of child and adolescent psychiatrists in the workflow. Depression is a heavy illness. It's familial, it's recurrent. Early identification and treatment is extremely important. And it has a serious impact on development of the youth and psychosocial functioning. Risk of suicide increases, as well as risk of substance use. You all are aware of the Surgeon General's advisory on youth mental health, as well as the increasing rates of suicide since about 2008. It is now the second leading cause of death in young people, 15 to 19. So I'm going to touch on guidelines in the GLAD PC, which is very well written and enunciated. So the GLAD PC, which are the guidelines, originally developed in 2007 and then updated in 2018 to address the gap between primary care and child and adolescent psychiatry. The updates have two parts. The first part, which we've covered in the past, is around identification. And the second part is on treatment, and that's the part that I'm going to focus on today. I would strongly recommend a read of the GLAD PC toolkit. It's got plenty of resources. There are certainly barriers to implementation, but it's a very well-resourced book. So the recommendations in part one, just quickly skimming through them. So this is pertinent to youth aged 10 to 21. And this goes into the preparation of the primary care practice, which is training, education, and networks. Annual universal screening, greater than age 12, with the PHQ-2, PHQ-9 modified. The whole purpose of this is to identify those high-risk youth, to assess them accurately using rating scales and interviews with the child, adolescent, and the family using DSM-5 criteria. Psychoeducation and support to the family, and safety planning. I want to underline here that in the assessment, it is very important to try to meet with the youth alone, because oftentimes that is where more information is obtained. And psychoeducation and safety planning is extremely important. using evidence-based materials, safety planning using the Stanley Brown safety plan. And then understanding and developing community networks for referrals in your practice is also very important. Moving on to part 2, which is treatment. So treatment, think about it in categories. You have mildly depressed youth that need active monitoring. And when the depression crosses over to moderate and severe, that's when more vigilance is needed. So treatment with medications and therapy in the case of moderate depression. And when that begins, when you start treating, it is going to be really important to monitor for side effects and to track outcomes. So how do you classify mild, moderate, and severe depression? You can use the DSM-5, you can use your PHQ-9. Less than 5 number of symptoms qualify for mild depression. It is definitely distressing, but manageable, and really focusing on impairment. Where is the youth struggling? And then severe is your closer to 9, which is meeting all the criteria. And this is now seriously distressing, unmanageable, and the symptoms markedly interfere. So depending on where your patient lands, you can generate an algorithm for treatment. So active monitoring, mild depression. So this period of time is about 6 to 8 weeks. And in this period, you want to schedule frequent visits, maybe weekly. Want to discuss regular exercise, leisure activities, peer support. Adolescents do really well with youth their own age, but sometimes they're not necessarily very kind to each other. Reviewing self-management, checking in with patients and families via telephone. And here, I think it's really important to underline that we need to check in with the youth as well, and providing patients and families with educational materials. So I'm going to go through the flow chart that GLAD-PC outlines. Follow with me and this cursor. So you have mild depression. You are actively supporting and monitoring for about 6 to 8 weeks. You're checking in frequently, and you've given them resources, and you're being extremely supportive. This may improve, and then they can then continue with their life and check in with you periodically. However, if this persists, then we may fall into the path of management and primary care, as we do when we are dealing with moderate depression. Going to moderate depression, here what you would do is you would start thinking about consultation with a mental health specialist, whether that means an integrated specialist in your area, referring immediately to a therapist in your network, getting on a wait list for child and adolescent psychiatry. So while you do that, you can then also consider managing in primary care. Severe depression and comorbidities. So this is the complex depression scenario. Here, I think the recommendation is really seriously move forward towards consultation with a mental health specialist, and referring on. When you come to the moderate and severe depression, that's where safety planning and discussing risk with the youth and family is going to be very, very important. Now landing back in management and primary care. So here you would initiate medications and/or therapy, and we will talk more about them in just a minute. You would use an evidence-based antidepressant, and really the 2 FDA-approved ones are fluoxetine or Prozac, and escitalopram or Lexapro. The evidence base also dictates that psychotherapy, evidence-based psychotherapy, is extremely useful in the treatment of depression. And I will give you some facts about psychotherapy very soon. So you initiate medications and/or psychotherapy. So with the medications, you start low, go slow. There is a chart in the appendix about the effective dosing. So, for example, with fluoxetine, the effective dosing is between 10 and 40 milligrams. When I say start low, go slow, you may start at 5, but pretty quickly need to bring it up to 10 with frequent monitoring. And As side effects permit, you would want to move closer and closer into the dose range 20 to 40 milligrams. But it is extremely important to monitor for symptoms response as well as the adverse effect, and consider an ongoing mental health consultation. Continuing down this pathway, so you now have started your patient on the medication, you've come up to the effective dose, they're tolerating the medications, you check in frequently, and then your final check about whether they've partially improved or not lands in that 8-week period. So you hear about 6 to 8 weeks, you hear about 8 to 12 weeks. So a nice round number to remember is 8 weeks. At that point, you want to optimize, make sure you've reached the end of the therapeutic range, which is sort of 20 to 40 milligrams with fluoxetine, and 10 to 20 milligrams with escitalopram or Lexapro. So optimize, make sure that the good effective dose has had enough time to work in the patient. And if there's partial improvement, what are we missing is the question. Add therapy, consultation, continue to review safety plan, and provide supportive education for the child, youth, and family. Going down this other pathway, if there's not enough improvement, then it's really important to reassess diagnosis. One thing as you're reassessing diagnosis is to think about compliance. Youth are notoriously non-compliant with medications. It's easy to forget. So that's important in that reassessment piece. Then again, are medications at fine-tuned to the optimal dosing? Or at this point, do we want to consider changing medications? And do we want to strongly recommend a component of therapy? And again, as you're reaching this, you want to activate your mental health consultant. So let's say your patient is really improved, and at that 8-week mark, moving on to 12 weeks, the symptoms are remitted. That's wonderful news. You then want to continue medication for 1 year after full resolution of symptoms. This is extrapolating from the adult literature. It is extremely important to monthly monitor for about 6 months, and I would say regular monitoring for about 2 years after resolution of that index episode of depression. The reason for this is depression, as I mentioned earlier, is familial, it's recurrent, it's heavy, and people quickly get off the medications when they're slightly better. And that then moves them into the path of non-response and recurrence even more. You have a great relationship with your patient and encourage them to develop that trust and therapeutic alliance with the mental health provider. Going back again to FDA approval, fluoxetine, Prozac, ages 6 and older, escitalopram, ages 12 and older. And as I said, the way I would start this, again, it varies with the patient, but potentially I would start with about 5 to 10 milligrams of Prozac, watch in weekly intervals, talk to them, get side effects, response, move them to 20 milligrams in that 2 to 3 week range, and get them in that 20 to 40 milligrams, closer to the 40 as tolerated, closer to 8 weeks. Escitalopram, start with about 5 milligrams, move them into the 10 milligrams range. The effective dosing is 10 to 20 milligrams, get them as close to the therapeutic dosing with side effect monitoring, and give it a good period of time of about 4 weeks on good dosing to then assess response and make sure that the youth is compliant. So phases of treatment, you have the acute, which is really to push the depression into remission. And then you have the continuation, which is also really important to consolidate the treatment response and prevent relapse. And then maintenance. So when I refer to the continuation phase, it's about the first 6 months to a year, you want to continue monitoring them closely, and then maintenance at least 2 years after that index episode has resolved. So continued monitoring, consultation with therapist, etc. Your choice of treatment in each phase depends upon the age of the patient, cognitive development, comorbidities, family history, family choices, preferences, and your treatment expertise. It's really important to think about how the family is handling this, because they're a very important part of your treatment planning, and also about cultural factors. Stigma is huge. Things to keep in mind: responders may have some residual symptoms. It's really important to measure not only this depressive symptoms being pushed down, going away, but also how is the child functioning? Are they meeting life where they need to be meeting life? And again, reiterating medication compliance, because they may come back and say, I'm not feeling better, but they may have taken the medicine 3 days in the week. The evidence base lies with the large randomized controlled trial study, about 2007, TADS. And really what I want to underline is the combination of CBT and Prozac showed a rapid decline in depressive symptoms, and the combination treatment better than Prozac alone for mild to moderate depression and depression with high levels of cognitive distortion. What does this mean? Adding that therapy component can again push that depression down, and especially when there's cognitive distortion, the child is really misperceiving what's going on. It is really important to have therapy. As depression gets more and more severe, you want to make sure the medication is on board. Pharmacotherapy, important to know that placebo response rates are high, 50%. SSRI response rate, 61%. Still important that we treat moderate to severe depression with a combination of the SSRI plus CBT. Depressive symptoms are very responsive to supportive management, which is why that active monitoring phase in that first 6 to 8 weeks is very important. Fluoxetine has the maximum amount of data, largest difference between medications and placebo. Venlafaxine, Effexor, not FDA approved, but studied in a recurrent depression study called Atordia, may be better for older children, but lots of side effects, shorter half-life. So while there is evidence, be careful. And tricyclics are no more efficacious than placebo. Side effects are many. GI side effects, headache, etc. These are some of the common side effects. What is really serious is the concern that the family has about the onset or worsening of suicidal ideation. What's really important to know is that the meta-analyses have really published that spontaneously reported suicidal ideation and or behaviors that is just mildly increased. No completed suicides have been noted in these studies. And studies have all concluded, right, that since the use of SSRIs, there is a decrease in adolescent suicide. In contrast, after the black box warning, when everyone stepped away from prescribing SSRIs, suicide rates increased. So it's really important to treat these kids well and correctly and monitor carefully. The other serious side effects that are important, there is something called behavioral activation, which is just the restlessness that a child experiences when starting an SSRI. I would be careful when you encounter that. I think the first step would be to lower the dose and see how the child handles that. Serotonin syndrome, because of interactions, can also be a serious side effect. So use of antidepressants, I've covered the 2 FDA-approved antidepressants. The others can be used too. There is no real head-to-head data suggesting that one is better than the other. But it's really important to take into consideration FDA approval, family comfort, response, and to know how to dose these medications. Pharmacokinetics in children, they kick out the medication sooner, so withdrawal is possible during the day, especially with medications that have a short half-life. Again, the wisdom is start low, go slow. And as I've mentioned, response should be assessed carefully. As you're assessing response, think about side effects, think about dosing, that effective dosing, and the number of weeks at an effective dosing that the child has been on. 8 to 12 weeks, that depression should have been pushed down into remission, or else we're looking at alternative options. Again, so we've talked about monitoring for suicidal thoughts and behavior. Frequent monitoring is really important. When there's a family history of bipolar disorder, it's really important to monitor for mania. I think that this risk is present, but I don't think it should be a worrisome risk. I think the monitoring should pick up, when a child truly moves into mania. When you're discontinuing the medication in an attempt to maybe switch treatment, it's really important that it's discontinued slowly. In the appendix, I have a taper-off regimen obtained from GLAD-PC as to how these medications can be discontinued. Fluoxetine has a long half-life, and that can be discontinued a little bit faster. Withdrawal symptoms can be very unpleasant, so slow and steady. And again, as I said, interactions with the SSRIs are important because serotonin syndrome can be pretty lethal. And for example, MAOIs and some antibiotics, dextromethorphan, etc., with the SSRIs can induce or can increase risk of serotonin syndrome. So continue treatment, move into continuation and then maintenance mode. And again, underlining CBT is very important. And if after a couple of years, the child has been doing really well, and the decision is made with the child and family to intentionally withdraw or take the medication off, slow taper, low stress period of time, and continue monitoring. So again, with the maintenance stage, I would definitely say 1 to 2 years, and maybe once the depression is pushed down and not there, quarterly visits just to check in. That when a young person has been tried on 2 antidepressants, again, a full therapeutic trial with evidence-based therapy, and the response then is still not there, that's when you're really in the realm of treatment-resistant depression, and the evidence there becomes increasingly scant. When one encounters treatment-resistant depression, I hope by this point that you're being supported by child psychiatry as well as mental health services for your patient. And really then the thought is, what are we dealing with? Have we missed a diagnosis? Is this a subsyndromal rapid cycling bipolar disorder? Is there lack of adherence? Again, what else is going on that needs to be addressed? NIMH Tordia studies the evidence for treatment-based depression in 2008. And this is a multi-center trial, depressed youth with failed response to the SSRI. So that then what do? 4 interventions were tried. Switch to another SSRI. So for example, go from fluoxetine to escitalopram or Lexapro. Add psychotherapy to your fluoxetine. Switch to venlafaxine or Effexor. Add CBT to venlafaxine. So results summarized. No difference in outcome between switching to an SSRI or venlafaxine. So you can either switch to another SSRI or you can switch to venlafaxine, keeping in mind the short half-life and the side effects with venlafaxine, especially in younger kids. There are side effects with venlafaxine or Effexor. If you add cognitive behavioral therapy to the medication and the medication change, so adding CBT plus changing medications really helps. Comorbidity, again, it's really important to favor combination treatments, which is medication plus therapy. There are categories of children who don't do very well with CBT, and that is another talk altogether. Trauma, which is rampant amongst the kids that we work with, has to be tackled slightly differently. So really the recommendation, the most robust response, switch to another SSRI and add cognitive behavioral therapy. So what is cognitive behavioral therapy? That was put forth by Beck and expanded upon. really working with cognitive distortions and increasing pleasurable activities. The other evidence-based therapy is interpersonal therapy, increasing interpersonal effectiveness. This is very effective in adolescents. Why? Because their world is about getting along and fitting in with their peers. With that, I'm going to end, and in the appendix is much more information that you can feel free to use at your convenience. Thank you.
Gary, we're not able to hear you.
I'm so sorry. That was spectacular. Thank you so much, and extremely clear and easy to follow for a primary care physician. Thank you. Ankita, Michael?
Yeah, I think Dr. Ranga, we've had you a couple of times as speaker, and I think what you've gone over are some really key important considerations, at least when we're first starting to think about treatment for depression, because we all agree there's a lot of it out there, and we want to do something, especially for our youngest population members. I want to turn it over to Dr. Dudas and Dr. Piazza to share their insights, and then we can delve into some questions. Dr. Dudas?
Hi, thank you. I don't know that I have a lot of insights beyond what Dr. Ranga shared. And, I guess my comments would be, one, thank you for kind of bringing the guidelines to life, because I think it's challenging sometimes to just follow guidelines, especially in such a, sort of complex issue. And when, no two patients present the same way. I think it's really helpful. I think the things that I think about with the guidelines are really how we do, I think, a really nice job often of screening. And I think you've really called out the importance of screening, recognizing that, 50% of children with depression maybe aren't identified until adulthood. That always sort of, emphasizes the importance of screening to me. And screening isn't enough because there is often such a big gap between the screen and effective treatment, right? And a big part of that is the importance of assessment, going beyond the screening process itself. And I think that's often where primary care providers feel a little bit at a loss of, okay, well, we've got someone with a positive PHQ, and, so we think that they have depression. I wonder if you might share, Dr. Ranga, just a few comments on, sort of how to do that assessment in primary care, sort of beyond the positive PHQ.
I think what is really important is the fact that, we often are rushed and there's not enough time. And sometimes I think we just need time with the patient and family in order to understand. So in terms of an assessment, I can bring my child and adolescent psychiatry hat to what can be done in your primary care setting. I think, again, it's really important to meet with the youth alone. What I usually do with the youth alone is to just talk to them about their life. And it seems like a very simple conversation about how they're doing, but I don't focus on the depression. So what I could be talking about is, tell me a little bit about school. What grade are you in, and what's fun and what's not fun. And they usually take a really nice approach. They sort of teach you what's really cool and what's not, and then that helps the therapeutic alliance. And then sort of trying to understand what's going on with their work, which then signifies difficulty with concentration, what's going on with their peers. Again, big concern for bullying and social media and fitting in. Then, just asking them about themselves, like, what is it that you are proud of? And what do you see yourself doing at the end of, high school? tapping into hopelessness. Do you think you're going to achieve that piece? There's also, it's an importance in understanding from them where they are with their gender and their sexuality and acceptance by peers and their online life. So it's really an exploration in a 360 way of the youth's life. With the parent, I would also delve into what's different, what's a timeline. Sometimes it's about normal adolescence. The child goes back upstairs and closes the door and wants to just do their own thing, and that's okay. But what's the mood like? Is it highly irritable? Is it that they're withdrawing? Their hygiene is going down. They have a lot of somatic symptoms. They're losing interest in things. So that's the sort of assessment in addition to DSM-5. As we move away from training, I find myself getting much more data from a semi-structured approach than I really do from a structured interview.
I just will comment that I appreciate those comments a lot. I think it's often, as we've talked about, hard to do that in, sort of our 20-minute well child visit when someone screens positive. And I appreciate so much you calling out the importance of that, just those open-ended questions versus sort of that checkbox approach, and how much you really do learn and build that therapeutic alliance. And we have to figure out ways, and especially I think with now the common availability of telehealth, like how do we plan a follow-up to really be able to dive in and get that information and get it accurately. So I really do appreciate those comments. Thank you.
Yeah, I think the other thing that American Academy of Pediatrics has called out before is that really we're not just treating the adolescent as the patient, we're really treating the family as that patient, right? I mean, and that's really a big challenge when dealing with some parents. I'm curious, have you run into any particular tips or tricks when dealing with perhaps the depressed youth who has those parents who are reluctant to start medications, or who have other thoughts on how their interpretation of the child's condition?
Absolutely. So one thing that I talk to about with my fellows and residents is, it's my schedule as a child and adolescent psychiatrist, but I'm very mindful of the fact that prior to this visit to either pediatrics or child psychiatry, there is a sense of failure in the parent as well as the child. Something invisible is going on, and it's scary. It's not as simple as I'm hurting here. So just being mindful of that potentially when you're entering that room, there's a lot of tension. That's why taking a step back for me also, I have to pause. And when I enter the room, when I feel that tension, again, I want to try to validate and separate. Oftentimes when I meet with the parents, I want to be validating, because, while they may seem irritable and angry, it must have been such a difficult journey to watch your child fall apart in the last few months. And that child is being prickly and irritable and argumentative. So I just want to be able to extend and hold space for them to say, gosh, this must have been really difficult. Like, how have you been coping with this? And that oftentimes opens up the dialogue. People relax a little bit. You see that in their body language. They start talking. And then you tap into what is the reason for the resistance to treatment. And we have to work with that. I mean, psychotropic medications are scary. There's a lot of material in the media, and there's cultural and familial reasons why they may refuse medications. And I think if that's the case, we educate, support, validate, and bring them back, and just keep building up that therapeutic alliance, and being clear, about suicidal risk, for example. That is a real concern, and so having those conversations and being open, I think, oftentimes helps parents feel a sense of agency, rather than being told, oh gosh, already they're feeling the failure, and then being told, chop, chop, you need to do A, B, and C, and not feeling comfortable with it. So I just think holding space and giving them some time to think and putting some agency back to them is helpful.
Absolutely. And having seen several of those kids that have transitioned to adulthood, many of them have said, gosh, I wish I started this as a teenager. And so I think anything we can do to help support that early treatment is key. So that's really helpful. I appreciate it.
I think just, piggybacking off of the question around culture and parents or caregiver, right? There's a question from Dr. Diaz in the audience, and I would love for each of you to weigh in on this. When you're screening an adolescent, like, how do you parse out what is the parent or the caregiver's influence of how a screening question should be answered versus the child's true feeling of how they want to answer the question? Because I'll be the first one to say many times, even at me as a kid, and I'm not an adolescent physician by any means, there were times where I felt, oh, there's a secondary influence of my parents sitting right there. So I guess I'll go to Dr. Piazza, then Dr. Dudas, and then Dr. Ranga.
Sure. I think part of it is making sure that we get the parent out of the room at some point, which we normalize as part of the well child exam anyway, right? We do the heads assessment. We ask the parents to leave for a few minutes, and I'll usually tell the parents, I'm really just going to ask them about X, Y, and Z. We'll recap. We'll have you come back in the room in a few minutes. We'll recap anything that's relevant, and so they feel a little bit more comfortable stepping away. But I think by building that rapport with the patient as well, you have that opportunity to start diving into what's the patient and what is the parent. And it is challenging. I mean, I don't think there's a great way to do it. But I think the more you see these kids, the more you bring them back, the more you build that rapport with the patient, I think the more you're able to kind of understand them, but also understand what's actually the parental influence.
I think the comments I'll make specifically around the screening is that I think I'll usually try to validate the answers in the screening whenever the patient or whenever the parents are out of the room, and I maybe as simple as they've marked zeros on all the questions, and so I'll just validate, hey, it looks like, have you had any issues with this? It looks like, you've shared that there isn't, and just validate that. But also when they indicate a positive answer, just ask some open question, some open questions around those, just to really maybe pull out a little bit more detail. And oftentimes I think you can hear the patient's perspective and also begin to understand if it's more the parent's concern or more the patient's concern. The last thing I'll comment on regarding this is that we did a improvement workshop around our adolescent care a few years ago, and one of the challenges that I think we all find is you have a parent with an agenda, you have a child with needs and maybe an agenda. And it's so important to provide opportunities for the parent to share their concerns, perhaps in an unstructured or a structured way. But we often found that, I guess I would say the flow of the visit was often challenged by not having a formal approach for the parent to share those concerns. And so we implemented a very simple, just a couple open-ended questionnaire for the parents to fill out at every teen visit, which served to, I think, distract the parent away from trying to fill out the child's questionnaire. And it also helped provide an opportunity for the parent to share those concerns. And it's been very helpful in terms of just capturing all that and integrating it in. And sometimes the parents are then very happy to just spend the time, especially in the older kids, outside of the room, recognizing that they've shared that concern and you can bring it up with their child in the right ways at the right times during the visit.
Yeah, and I would just add two comments. One is, I think when we dismiss the parents, we need to be sure that the child is not losing or adolescent is not losing their security blanket. Now that I'm in here with the doctor. And so probably to me, that first step is reconnecting with the patient. And I really appreciate you taking time to talk to me, and I'm really want to listen and be here for you. And so that there is that therapeutic alliance, I think, is key. And Dr. Ranga, and then we probably need to close, but I just wanted to underscore one thing you said, and that's the importance of frequent follow-up. I think a lot of times, particularly in a busy family medicine or pediatric practice, it's like, oh, maybe you could come in 2 or 3 weeks because I'm crazy next week. But I do think that once or twice a week is really important for a while to really be sure that you're on the right track, that you've cemented those relationships. And even if those are shorter visits, it makes a huge difference. And I think we really don't take advantage of frequent visits the way that we should. Having said that, there is one more question, and then we'll close. Dr. Dudas, could you please share the reference parent questionnaire with our team? Thank you, Deborah Rockman. So I don't know if you see that. Yeah,
I don't see that, but for sure, yeah, we can
okay, great. Thank you, Deborah. Yeah. So I just want to say this has been a wonderful morning, and I think extremely informative, well thought out, and great food for thought for all of us. So we're very thankful to you, Dr. Ranga and Dr. Dudas, Dr. Piazza, for being part of this, and Dr. Sagar and Rachel and John, all for planning this. It's really been a spectacular morning. Dr. Sagar, any last comments?
I just want to give a big shout out to all the teams that are working so hard in the background. And I know, Dr. Piazza, one of the questions we were going to ask you was walk us through all the work that goes from the paper guideline into actual clinical EMR. I want to give you just a few seconds to speak to it, and then we can wrap it up for sure.
Sure, no, that's fine. No, there's a tremendous effort going on at the national level to try to capture a lot of this information appropriately in all of the different EHRs. And that's been one of the challenges, frankly, is we don't have one EHR, we have multiple. And we want to make sure that we're using the right tools that are appropriate for adolescents and gathering those across the ministry. So there has been a number of efforts, both especially focused on Cerner and the Epic markets, and trying to make sure that PHQA is appropriately captured in the EHR, that there's opportunities for that data to be discreetly entered, that there's back-end reporting and analysis going on behind the scenes with that as well. And then also just some training that goes along with that, right? I mean, we can give you all the tools in the world, but they don't do any good if people don't use them. They're not intuitive. And so there's, as I would actually encourage all of the clinicians, as you see these tools, as you use these tools in the EHR, please provide us feedback. Let us know let your informaticians know, how is it working? How is it not working? What are you missing? So that we can continue to refine and improve these, because we really need that boots on the ground kind of feedback to help continue to refine the work that we're doing. So.
That's great. And for all of these projects, the digital support is so important. So let's see here. Laura Keller raised her hand and has put a comment in that says the toolkit is exceptional. And I do want to say, and I've said this many times, I think for the whole depression screening, adults and pediatrics, the amount of support in terms of these toolkits and other accessory materials has just been great. So I think that captures Laura's message. So again, thank you. It's Friday. I hope people have a great weekend and be safe. And we'll see everyone next week, same time, same station, early in the morning in California for suicidality. Dr. Ranga, thank you.